Hello everyone, it is my great pleasure to be here and present our latest results from the first-in-human ImmunoPET imaging of COVID-19 convalescent patients using dynamic total body PET scans on the Explorer scanner with a CD8 targeted minibody tracer. So here's my disclosure. And I'm going to start my talk with a short introduction on CD8 T cells. CD8 is a cell surface protein expressed by some of our white blood cells. Among these cells, CD8 T cells are one of the two major types of T cells and play a key role in immune response against both viral infections and cancer. But what makes it important and interesting to image CD8 T cells in COVID-19 patients? During a viral infection, naive CD8 T cells become cytotoxic T cells that are antigen-specific and directly attack and kill viral infected cells. After viral infection or vaccination, some of the surviving cytotoxic T cells differentiate into antigen-specific memory CD8 T cells and form a long-term protective memory against reinfection. However, there is very limited in vivo information about COVID-19 specific T cell immunity. And this is because 95% of T cells are in tissues and not in the blood circulation. The aim of this study is to provide a first-in-human in vivo measure of tissue distribution of CD8 T cells after COVID-19 infection. And for that, we are using a zirconium-89 labeled minibody, which has high affinity for human CD8. But what does total body PET offer for ImmunoPET imaging? We know that total body PET scanners with their extended axial length offer significant sensitivity increase compared to conventional PET scanners, and in general they allow us to image with higher SNR, image faster, image longer, and at the same time have total body coverage. Now, zirconium-89 based ImmunoPET tracers have a low positron fraction and a long half-life, and as a result of that, their high radiation dose has prevented their wider application in non-life-threatening disease and healthy populations. The high sensitivity of total body PET now enables high signal-to-noise ratio imaging of ImmunoPET tracers at substantially lower injected doses, in addition to capturing the kinetics across all the organs and tissues of interest with dynamic imaging as well as late time point imaging. And this enables complete characterization of the pharmacokinetics of these tracers across a wider range of applications. Therefore, this makes total body PET currently the only available technology that allows us to non-invasively do in vivo measurements of T cell distribution and kinetics inside all tissues in human subjects with acceptable radiation dose burden. So now looking at our pilot study design, we had 8 subjects in total, including 5 COVID-19 recovered patients and 3 healthy controls. The first 5 subjects were COVID-19 recovered patients, all female, and will be shown with shades of blue throughout this presentation. And the last 3 subjects were healthy controls, 2 male and 1 female, and will be shown with shades of red. The study included PET-CT scans and blood sample collection, and we injected only 0.5 millicurie of the zirconium-89 labeled CD8 minibody at a 1.5 milligram minibody dose. The subjects were scanned at 3 time points, including a 90-minute dynamic scan, followed by 2 60-minute static scans at 6-hour and 48-hour post-injection. Only 2 of our COVID-19 patients did not have the 90-minute dynamic scans, and 1 of our controls only completed a 65-minute dynamic scan. The COVID subjects were not hospitalized during their infection, and they were first scanned within 8 weeks from the onset of their symptoms and then returned again after 4 months for follow-up scans. All subjects were vaccinated except for one of the healthy controls, and age and BMI range were similar between the two groups. However, our COVID-19 group was quite heterogeneous, and here I will show the timeline of vaccination, COVID-19 diagnosis, as well as our PET scans compared to the COVID-19 rates in California and the different variants of the virus. So our first subject got COVID before vaccination, and her first PET scan was between two vaccinations. She had the most severe symptoms and also some pre-existing conditions. Our subject 2 got COVID twice. The first time was between the two vaccinations and then had her PET scan after getting COVID twice. Our subject 3 got COVID after 2 doses of vaccine and then got scanned. Subject 4 got 3 doses of vaccine and she got COVID during the Omicron variant surge. And our subject 4 also got COVID after 2 doses of vaccine, had the mildest symptoms, and she got COVID after the Omicron surge in California. Now, before I start showing you the detailed results of this study, first I would like to show you a side-by-side comparison of the image quality we used to get on conventional PET scanners at different imaging time points with this tracer and what we are getting now with total body PET at 1/6 of the injection dose. And you can see the remarkable image quality here, especially if you look at the uptake in bone marrow or lymph nodes, for example, in this subject throughout the body. Now looking at the images of our 8 subjects here, you can see the 6-hour time point and the 48-hour time point images for all subjects. On the left, you can see the 5 COVID subjects, and on the right, the 3 controls. In both groups, you can see that the highest uptake is in the lymphoid organs that contain T cells, and this includes spleen, bone marrow, lymph nodes, and tonsils. But also we have some uptake in the liver, gallbladder, kidneys, and the bowel. And we also saw some uptake in the lymphoid tissue in the nasal and paranasal area, and very low uptake in muscle, myocardium, and the brain. And you can see that subjects showed different extended lengths in bone marrow uptake of the humeral and femoral shafts. And also you can see that the lymph node uptake peaked at the 48-hour time point in all subjects. And we saw high uptake in several head and neck lymph nodes of all subjects. And some of the subjects also showed lymph node uptake in their axillary, pelvic, mediastinal, as well as upper and lower lymph nodes. Then also comparing the 4 months follow-up scans of the COVID-19 subjects to their baseline scans here, you can really see striking similarities between these scans within each subject, especially again if you look at bone marrow or, for example, the lymph node uptakes in every individual subject. Now looking at the image-derived whole blood time activity curves that we got from the left ventricular blood pool here, you can see the first 90-minute data from the dynamic scans at the top and the whole 48-hour data at the bottom. And you can see that the whole blood clearance curves were best described with a tri-exponential function with initial, intermediate, and terminal clearance phases of about 5 minutes, 1 hour, and 22 hours. The clearance rates were, the half-lives were relatively similar between the two groups, except for one of the COVID-19 subject 2 who got COVID twice, which showed significantly longer terminal half-life compared to all other subjects. Then we did some volume of interest analysis on all subjects, looking at different regions of bone marrow here, also at spleen, lymph nodes, tonsils, nasal cavity, liver, and lungs in all subjects. And you can see very consistent trends in the time activity curves of all subjects. And for example, between the 6-hour and 48-hour time point, we see this decrease of uptake quite similar in all subjects in bone marrow, spleen, and lungs, and nasal cavity. At the same time, we see this parallel increase of uptake in lymph nodes and tonsils. Also, zooming in on the first 90-minute data from the dynamic scans, you can see the high quality of the time activity curves we are getting in different organs in all subjects. Next, we looked at the kinetics of the tracer in the bone marrow specifically as the main storage site of CD8 memory T cells, and looking at the SUV time activity curves alone from the first 90-minute dynamic scan, you can see that we don't see a clear difference between the subjects in the two groups, the COVID group and the control group. However, when we look at the tissue to blood ratio curves in the bone marrow during the first 90 minutes, now we can see a clear separation between the two groups with higher tissue to blood ratio in the COVID group. And now if we also add the 6-hour time point data and also include the two COVID subjects that didn't have dynamic scans, you can see that still we have higher blood and tissue to blood ratio in the bone marrow of all COVID-19 subjects compared to controls. However, when we include the 48-hour time point, now you can see that this correlation is lost now, and this could be partly because of the effects from T-cell trafficking. So then we looked at tissue to blood ratio of different organs, and here you can see the results, and we see higher tissue to blood ratio in bone marrow as well as liver and tonsils of COVID-19 patients compared to controls. And we interestingly see significantly orders of magnitude two or three times, I think, higher response in one of our COVID subjects who got COVID twice compared to the rest of the COVID subjects. Then we looked at the longitudinal changes in the 4-month follow-up scans of our COVID-19 patients, and we see again a consistent trend in different regions of bone marrow towards an increased tissue to blood ratio at the 4-month follow-up scans. Next, we tried to do some kinetic modeling on our 48-hour data with AIC model selection. And the main mechanism of uptake for this tracer can be simplified and approximated by a 2-tissue compartmental model with 4 fitting parameters of VB, K1, K2, K3, and with a 0 K4. And this is because basically the free tracer enters the tissue, it binds to CD8 receptors, and then gets irreversibly internalized within the cells. However, in presence of T-cell trafficking, which is non-negligible during the 48-hour period of imaging in lymphoid organs, all rate constants between the different compartments will include components from trafficking, and the model will require non-zero K4 to represent the trafficking of radio-labeled CD8 T cells out of the tissue back to the blood. Therefore, we looked at 2-tissue compartmental model with and without K4, as well as 1-tissue compartmental model in all organs. And here you can see AIC model selection results in different organs. You can see that in spleen, for example, the 2-tissue model with non-zero K4 2T5P is largely favored in the spleen, where a large population of naive recirculating CD8 T cells are expected, and the migration of radio-labeled CD8 T cells out of spleen should contribute to this non-zero K4 basically. We can also see a kind of similar effect in bone marrow to a lesser extent, that the model with a non-zero K4 is favored. But for example, if we look at the lungs, and especially in the healthy subjects with healthy lung tissue, we don't see much of a difference between the 2T5P and 2T4P model. So in healthy lung tissue, a large fraction of CD8 T cell population is expected to be non-circulating tissue-resident T cells, and that explains the small difference between the two models here. And we do see a difference in the COVID-19 subjects where, again, a non-zero K4 is favored. In case of tonsils and lymph nodes, where we have much lower blood flow compared to spleen, bone marrow, or lungs, for example, the free tracer basically very slowly enters the tissue and binds relatively quickly to the highly available binding sites in these tissues, and therefore we can probably use a one-tissue compartmental model in these organs. Now looking at the net influx rate, Ki, of the two-tissue compartmental model, we saw a high correlation of Ki with the tissue-to-blood ratios from the 6-hour time point, and in bone marrow, again, we see increased values in the COVID group and a much higher response in the patient who got COVID twice, and this increasing trend at 4-month follow-up scans again. Comparing these imaging results to the immunophenotyping results on our peripheral blood samples, we also saw higher frequency of CD8 T cells in general in their blood, but also higher frequencies of activated T cells and memory CD8 T cells in the blood of our COVID-19 patients compared to controls. And we do see this increasing trend again at the 4-month follow-up scans. Lastly, we saw some really interesting uptake in the thymus only at the 48-hour time point of two of our subjects, one of our COVID subjects at both baseline and follow-up scans, and also one of our control subjects. And both of these subjects were our lowest BMI subjects. And given that the blood-thymus barrier should separate thymus T cells from blood circulation, and there has been evidence in animals that a small proportion of thymic mature T cells are immigrants from periphery, we believe that this data also suggests that we are actually imaging CD8 T cells that are labeled already outside thymus, and now they have migrated to thymus at this 48-hour time point. In conclusion, we have shown that using total body imaging of CD8 T cells with only 0.5 millicurie of a zirconium-89 labeled tracer allowed quantifying rates of uptake and concentrations of the tracer throughout the body with remarkable image quality. Kinetic modeling results were consistent with T cell trafficking effects expected from the immunobiology of the organs. Tissue to blood ratio from the first 7 hours of imaging was correlated with Ki, and it was higher in the bone marrow of COVID-19 patients compared to controls, and was the highest in one of our COVID patients who got COVID twice, and it increased in all bone marrow regions in all COVID subjects at the 4-month follow-up scans. And this suggests larger memory T cell pool or increased CD8 expression in bone marrow of COVID-19 recovered patients compared to controls. And lastly, high sensitivity of total body PET combined with the recently developed ImmunoPET tracers now provides a new platform for non-invasively and longitudinally studying the immune response and memory in all organs of the body in individual subjects in basically all processes that challenge or stimulate the cell-mediated immune response. With this, I would like to thank everyone who contributed to this project, and thank you for your attention.